I now know she had vaginismus. I didn't know at the time even what that was. She came in complaining of painful intercourse, couldn't even have any type of penetration. We couldn't do an exam. And I thought there's some sort of actual physical problem. So we ended up actually taking her back to surgery. They gave her medication to put her to sleep and relax everything, and everything was fine. And I remember being like, what is this?
Welcome to Babb. Millions of women are living with vaginismus and vulvodynia, and they think they're alone. I'm Mathilde, and I spent years struggling alone until I finally got the help I needed. In this podcast, I'm bringing you the very best experts to answer every question you have. Let's get into it. Today's guest is someone I've been really looking forward to having on the show. His name is Dr. Babb, and if you're in this space, there's a good chance you've already come across him on social media. He's a board member of ISSWSH, he's deeply passionate about women's sexual medicine, and I think he just has this incredible ability to take really complex science and make it accessible without dumbing it down. He just gets it, and I'm a huge fan of him. In this episode, we're talking about Botox therapy for both vaginismus and vulvodynia, a topic that I wanted to cover for a long time and actually have been very curious about personally. And I think by the end of this conversation, you'll feel like you have a really solid understanding of what Botox therapy involves, also who it might be right for, and actually what the science behind it is. One quick heads up, the beginning gets a bit technical because we talk about how vaginismus is graded in terms of severity using something called the Lamont scale. And Dr. Babb and his colleagues actually added a 5th grade to that scale based on what they were actually seeing in practice. It sets the stage really well for the rest of the conversation. I think this concept of the grading scale is actually really important for standardizing how we understand different expressions of vaginismus. So stay with it. And I truly hope you enjoy this episode. So first of all, a huge welcome to you. I've been really looking forward to this conversation.
Thank you so much.
So I think it is so clear that you are incredibly passionate about women's sexual medicine. That enthusiasm really shines through in everything that you put out there. And I'd love to start at the beginning, understanding what drew you into this field. And I ask this typically to my guests because I just genuinely think origin stories are really fascinating.
Sure.
But I will say I looked into your background before this interview and I was particularly interested about hearing your story because I noticed that you actually have a BA in music theory and composition, which is not exactly the typical pre-med trajectory. So I'm particularly curious about hearing about your path.
Yeah. So when I was in college, I majored in music composition. I originally wanted to be a laryngologist and help people with voice disorders. So spent a lot of time doing that. And then it really kind of that field boiled down to a lot of acid reflux and things that I was not really like super passionate about. My father was an OBGYN and I never really thought about doing that, honestly, but grew up very much in a household where women's health, women's sexual health, hormone stuff was very pro forward and was really talked about. And so when I got into med school, I really was interested in endocrinology and doing reproductive endocrinology. And so that's really what I wanted to do, kind of a very much a path switch from the laryngology route of stuff. And so I went into OBGYN residency and really just kind of through that process fell in love with these little niche areas of gynecology that didn't really get a whole lot of support. And I remember being out in practice, some of my first patients, they came and asked about low sex drive. They asked about lichen sclerosis. And, we maybe got an hour of a lecture, something like that, some minuscule amount in training. And I didn't have answers. I didn't like not having answers for people and not knowing what to do. So I started doing my own research in it and then found ISSWSH, which is the International Society for Study of Women's Sexual Health. Joined that and started going to meetings and then got onto academic faculty at Oklahoma State University and became an ISSWSH fellow and then kind of translated all of that to kind of the, sexual medicine, menopause and vulvar disease and eventually ended up starting my own practice in 2023. And here we are.
Yeah, brilliant. And was there a particular patient case or a moment during your training that kind of crystallized for you just how important and underserved this field of sexual medicine and women's sexual health was?
Yeah, so they're actually one of the patients I very distinctly remember this I now know she had vaginismus. I didn't know at the time even what that was. And, we couldn't do, she came in complaining of painful intercourse, couldn't even have any type of penetration. We couldn't do an exam. And I thought, oh my gosh, there's actual stenosis or narrowing here. Like there's some sort of, actual physical problem. Maybe she has scar tissue or something like that. So we ended up actually taking her back to surgery. And, they gave her medication to put her to sleep and relax everything, and everything was fine. And I remember being like, what is this? And I was a, second year resident, so still in training. And my attending was like, well, sometimes, they're just really nervous and, you get them, relax them and it goes away. But that stuck with me. And I think honestly, that specific case is what has kind of led me down, kind of started the path down to where I am today.
Very interesting. And I think we'll probably get to that within the next section now, actually, because I just want to say I really love talking to passionate people like you who are not only making a difference in their clinical practice, but who have also contributed to the science of how we understand these conditions in the first place. And I think that's actually the perfect place to start before we get into Botox as a treatment, which is the main topic of the conversation today.
Sure.
Because I think that will give us an even better understanding of who that is actually for. So I'd be very keen to hear more about the paper that you co-authored in 2019, which did something quite significant in extending our understanding and classification of vaginismus specifically.
Yeah. So, Peter Pacik, who was the other kind of big co-author on that, he is a plastic surgeon, or he's retired. And he was one of my mentors in training. We actually met at an ISSWSH meeting. And I remember I had seen his name, like searching for vaginismus stuff. And, he made this technique and it was helping all these patients with it. And I actually just serendipitously ended up having breakfast with him one morning at ISSWSH. And I was like, oh my gosh, I know you're the vaginismus guy. And he then kind of went off and, we struck up this whole talk, but, that I think as far as what got me really passionate about treating vaginismus was seeing kind of what Peter had done with his research. And, prior to that, you had the original papers done by Lamont, which basically graded vaginismus from a grade 1 through grade 4. And they were all really looking at kind of physical symptoms, if you will. And so with our paper, what we were able actually to do was to get actual muscle recordings of what was going on, and then also kind of take that grade 1 through 4 and add that grade 5 to be the Lamont-Pacik scale that encompasses almost like a pure dissociation with patients. And we've seen this in clinical practice to where these patients, they literally, it's like someone flips a switch on them when they're about to have an exam or something, and they completely dissociate. They don't know where they are, what's going on. They'll start screaming, and it's a terrifying thing, especially for the partner of the patient. The patient doesn't often know kind of what's going on with it. But we were able, as we went through that grading scale, to actually have measurements of the muscles themselves to kind of see what they were doing, and saw that, hey, there actually is a musculoskeletal component to this. It is not just a kind of anxious vagina that a lot of people had talked about before with it.
Yeah, exactly. So you added this grade 5, which was essentially capturing one patient class that was, in your experience, kind of falling off the cliff of
Correct.
Severity on the grades that was previously recognized in that 4-point scale. And yeah, it's really interesting reading that research paper or report, because as you allude to, you're not only describing, severe muscle spasms, but also these very visceral responses like nausea, hyperventilation, desire to flee, which wasn't part of the scale before. So can you walk us through briefly just to get an understanding of how that scale works? Because I don't think many people, or I wasn't aware of it before I started looking into your work and preparing for this interview. So can you walk us through what that actually, what that 5-point scale tries to capture from 1 to 5 in terms of severity?
I think that the best way to think about it is kind of, if you imagine the fight or flight response, as it gets more and more kind of severe in that. So a grade 1 patient with vaginismus, they will have kind of that initial muscle spasm, but they are able to relax. They are able to allow penetration to happen. They are able to allow a gynecologic exam to happen, whatever it may be, and are able to relax that tissue to allow penetration. When you get into grade 2, they are unable to do that. Now, they may be able to sit there if you're doing an exam and say, I just can't, that's uncomfortable, but they're not starting to show some of the other reflexive kind of visceral responses. So as you get up to grade 3 and grade 4, we start seeing things like leg locking, where, just literally the legs are kind of coming close together. You see, kind of the hips raising up. You see patients almost kind of are physically withdrawing away from the examiner or sexual partner in that case. And then obviously you get into the grade 5 where they're having these other signs of autonomic or sympathetic reactivity, basically.
Yeah, it's really fascinating to hear about this. And I think to me, seems incredibly impactful because that shared language for severity feels like it's genuinely important infrastructure for a field that has been very underserved as well. And one thing that really stayed with me from reading the study is that the muscle spasm in the most severe patients is so powerful that it can actually persist under light sedation as well, if I understood it correctly. Can you talk a bit about that? You were alluding to a bit earlier, but it was just, very interesting points.
And so that's when you talk about kind of with sedation, obviously there's a bunch of different types, and when we're doing a lot of the procedures to treat the vaginismus, we have this under more of a conscious sedation because we want to still be able to feel that muscle, tone. But the fact that in the original studies, these patients, you were able to still have that vaginismus response harkens to even more of an autonomic, sympathetic, that fight or flight response that's there. So even if the conscious mind is quote unquote turned off, the subconscious is still there and trying to protect that space. The neuroplasticity, that term that says the body is going to react in a way subconsciously dependent on what factors have influenced it historically, that is still overriding even that light sedation. So yeah.
It's incredibly fascinating. The Lamont scale, right? It captures two things simultaneously, the actual muscle hypertonicity, but then also these behavioral and psychological distress responses around examination that you discussed earlier, which I guess aren't necessarily the same thing, right? Or there's not necessarily, I guess, a direct correlation between the two. Do you ever use in your practice some type of objective measure of hypertonicity? Like, I think one of the ones that you can use is an EMG to disentangle those two components.
So to answer the first question, you definitely can do EMG. The issue in a non-research-based setting is, that's actually a very uncomfortable test. You're actually getting needles stuck into tissue for a true EMG. Now, you can do a little bit of either dolorometry, which is measuring kind of pain response, or actual pressure gauging with things. It's not the true EMG for that, but outside of most like research institutes, they're not going to be doing that in their own clinical practice. So when I'm evaluating vaginismus patients, I don't have a specific, tool that I'm saying, I'm getting this much contractile force based off that.
In the Lamont scale, you have these two parameters, right? The hypertonicity and the behavioral and psychological distress responses. You can have an extensive psychological distress response while still having fairly low hypertonicity. I was just curious about how that assessment is made in terms of treatment as well.
Well, and here's one of the interesting things. You can have someone that has I'll just kind of use the term severe vaginismus response in partnered sexual activity, and they have no response in the gynecology office. And so they are independent kind of variables there, because you can have someone who is incredibly nervous, who goes in and, maybe they're sweating, their heart rate's up, they look like they are distressed and they don't have vaginismus. They don't have that reaction. So, there is something in the patient who has the vaginismus response in the office and with other penetrative activity and I'll go back to that neuroplasticity that has associated penetration with, an abnormal, unwanted kind of sensation. And so their mind, kind of the stress response there, it can be heightened or deadened depending on which environment that they're in, regardless of what the muscles themselves are actually doing.
And is this 5-point scale then now widely known across medicine and gynecology? Because my assumption is that many people listening maybe will never have had their vaginismus graded at all. But what is your experience of how prevalent the scale is being used in clinic?
Well, so, and we can look at, if you go onto the National Library of Medicine or PubMed or things like that, you can see how many times the studies have been cited. And, there is it does get cited here and there, but overall, and this gets into a point of pressure, if you will. And then in the DSM, the most recent iterations of that, vaginismus has been taken out of its own thing and is lumped into genitopelvic pain and penetration disorder, this whole big thing, and actually got into a little bit of a heated discussion one time with one of my colleagues at ISSWSH who says vaginismus isn't a thing. It's just really tight pelvic floor muscles and they're anxious with it, so it's not its own entity. So I think that, even though we have this way to kind of really say, you are a grade 2 or you are a grade 4 or whatever, people that either A, aren't really working in the vaginismus space much may not be aware of that, or B, if they say, okay, well, this is just a manifestation of genitopelvic pain and penetration disorder, well, that's its whole other, kind of thing and wouldn't use it. So it's there. There's research that's being done that quotes or cites the article, but I don't know really how widespread it is in the general gynecology population.
Okay, interesting. And what is the benefit of including vaginismus or kind of redefining vaginismus as something that falls under GPPPD under the DSM classification?
Well, this is just my own opinion. I actually don't think, I think it's actually made things worse for patients with that. Because the GPPPD, I mean, that just basically says that anything that's painful can be in that, and so, okay, so you have, provoked vestibulodynia, let's say you're having pain with penetration because of some sort of that. Well, that's falling into that category too. So I think when treating patients with vaginismus, it is a specific way to look at them. And I think that's where the disservice comes from when you just lump it into a larger umbrella term, personally.
Yeah. Okay, so now we have a really clear picture of how we can classify vaginismus severity, and I would love to then bridge it into the main discussion of today, which is to understand a bit more about Botox therapy. And before we get into the detail, I just wanted to clarify that we'll be talking about two different treatment protocols. One, which is the more commonly used way of using Botox for vaginismus, and then there's this other protocol that you specifically are trained in and a handful of other practitioners are trained in. So I just wanted to make that clear before we go any further. But before we go there, I wanted to just touch on exactly what is Botox and what is it actually doing inside the body.
So basically there's a bacteria called Clostridium botulinum, and it basically secretes a toxin that causes muscle paralysis. And so what Botox is onabotulinum toxin A, and you basically have a powdered formulation of that toxin that's reconstituted or mixed with saline to create a mixture. And when that is injected into a muscle, it prevents that muscle from contracting. Now, it takes a time for that to set up, so it's not an immediate effect. You could not inject Botox into someone's, heaven forbid, like into their heart or something like that as like an immediate way to stop their heart from beating. It takes a while for that to happen, usually about 3 days. And so when we are using it, and it has a lot of different uses throughout medicine, all of which, including the cosmetic uses, are to cause muscle paralysis so the muscles cannot contract. So that's basically what it is, specifically. And there are other types too. There are other formulations of it that last longer, that are shorter acting. But we use for our stuff the just regular old Botox, which is the onabotulinum toxin A.
Yes. Okay, great.
Yeah.
And can you walk us through what's actually happening physiologically when Botox is injected for vaginismus? And also, I would be curious to hear how long we've been using Botox as a treatment for vaginismus as well.
Yeah. So when the kind of the standard way of doing the Botox injections is targeting the muscles in the pelvic floor that are causing the spasm. Typically, that's going to be in the pubococcygeus and the bulbospongiosus muscles more towards the entrance of the vagina, kind of in the introitus there. Now, a lot of patients with vaginismus will also have deeper pelvic floor muscular spasm too. And sometimes people will go in and inject those muscles as well. But the usual technique is to go and, if my hand is a muscle here, I take my needle and I inject the Botox in directly into that muscle. And, then you're done. The amount of dilution that you provide controls how much it spreads. So the more dilute the Botox mixture is, the more of a spread you get. So you may have someone who takes 100 units of Botox and they dilute it in 10 milliliters of saline, and it's going to spread quite a bit. Or conversely, someone who dilutes it in 1 milliliter, and every injection you do is going to have a very tiny spread of that toxin.
Okay, interesting. And how do you determine how dilutive you make it? Is it different depending on which muscle in the pelvic floor you're targeting, or what is that?
There's a lot of kind of individual practice with that, in total honesty. Now, sometimes if, we have, and the way that I was trained, this is kind of gets into a little bit of different ways of doing it too. The way that I was trained, we typically used a 2 milliliter or up to 4 milliliter dilution, usually the 2 milliliter. So getting, a very small spread, but the flip side of that is we do actually a lot of injections. In our case, the average patient may have around 40 to 60 injections of that toxin, and we're kind of doing it very much in almost like a peppering fashion. So, here, 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 as opposed to some of my colleagues, which say, well, I dilute it into, 10 cc's, and this muscle gets 5 cc's here, and this muscle gets 5 cc's here. And they let the spread kind of do the work.
Okay.
Yeah.
Understood. Very interesting to hear about. And so I'm curious to hear more about, because one of the central components that a lot of people talk about when it comes to vaginismus is this pain-fear-spasm cycle, right? So I would be curious to hear your view on how Botox therapy kind of relates to that phenomenon, if you will, in terms of what it can help with, and how it may also complement other therapies like dilator therapies or physiotherapy or psychotherapy.
And so I think that's, part of the treatment with it. What the Botox is doing is going to keep the muscle from firing. And so what that's going to do kind of in turn, when the muscle is continually spasmed, it's going to have decreased blood flow. It's going to not feel good. And so a lot of times patients, even if they have just vaginismus, after the Botox, their pelvic floor and kind of those muscles, it feels different to them. The way that you combat, though, that neuroplasticity effect of it, that's really where the dilator training or physiotherapy really comes into play. Because now you have to retrain the brain into thinking that something touching that tissue is not dangerous.
Yeah.
And so the Botox keeps the muscle from firing. So we know we're not going to get that actual physical pain response from the muscle contracting and being locked into contraction. So now how do you then tell someone who, for instance, I say, I don't want to shut my hand in a car door, right? I know that's going to hurt. Even if you were to pad the door and pad my hand, I would still have apprehension about putting my hand there and pushing a car door into it. And so using that kind of not so great analogy, what we're doing with a dilator therapy or physiotherapy is hitting that hand with the car door over and over and over and over and over again. And eventually I'm like, okay, yeah, I know that my hand's going to be fine because the car door is padded and I'm wearing this glove and it's not going to hurt, even though initially there was quite a bit of apprehension there.
Yeah, I actually think that's a brilliant analogy. I've never heard that before, but it's very it's very discreet in a way, or it feels very visceral. You can imagine what that feels like and how it ties to a lot of that apprehension that people who have experienced penetrative pain have. So I think this is actually a good analogy. So it's kind of, is it fair to say that Botox almost creates a window, a period of reduced muscle tone that allows other treatments to actually work?
I think that's a very accurate way of doing it, because there are people, and I'm sure and if you look on any of the vaginismus, message boards, whatever, that they are able to achieve pain-free, penetration with physical therapy alone or with cognitive therapy alone. So it is not the end-all be-all, but it is an accelerator. And I think that's the best way to think about it. With the Pacik protocol, we were able to get between 90 to 95 patients, I can't remember his exact number, to have pain-free sex within 3 months.
Wow, that's incredible.
And that is, that's kind of, we're at around 95, my clinic right now, percent of that in 3 months. But the other part that does not address then is now you have to work on desire, because just because you can say, hey, it's not going to hurt, and they can try and do it, like, they're right, it doesn't hurt, like, ooh, but I still don't really want to because I've been conditioned that it's going to hurt too. So it's very much a multifactorial thing. And I think that's why a lot of kind of general practices don't really address it much, because it takes a lot,
Yeah. I'm so glad that you raised that. That's one of the things that I am so curious about learning more about, because I feel like it's not addressed enough. That desire piece, and how, from my personal experience, how effectively your body dials down desire to protect you from that pain, and how persistent that is. And I was so excited. We were both at ISSWSH, and I was lucky enough to meet you there in person. And I was so excited to see just how much focus there was on female desire during the conference, and these newer medications coming into the market, and so much like enthusiasm and oomph around that. And I would love to do a separate episode on the piece around desire when you experience, or lack of desire when you experience, genitopelvic pain, because it feels like a very important part of the puzzle that maybe a lot of us don't have the tools to like navigate fully.
Yeah, I like to use kind of this waterfall analogy with it. If you think about the 4 domains of, when we talk about sexual medicine and sexual dysfunction, the 4 things that there are potential issues with. So desire, arousal, orgasm, and pain. You always treat pain first, because if something hurts, you don't want to do it. And then after that, you got to work with, okay, well, can I have the response to that stimuli? So you're going to treat desire or arousal next. And then, am I getting something out of this? So I'm going to then treat orgasm next. And then finally, you work on desire. Because it does me no good to give you, let's say, if I were to give you a shot of, Vyleesi, which is one of the 2 FDA drugs for low sex drive, but it hurts every time you have sex. You have substantial vaginal dryness because it hurts. And because you're tensing up, you can't orgasm. It does no good if you're like, okay, I really want to, but. And so you have to piece all of these things apart to get to this. Desire is always the last thing you actually work on. Because unless everything else is working, it's not going to do its thing.
That's a really helpful nuance. And I would love to discuss, I think it's maybe out of scope for today, but to discuss the potential use case of, as you say, like drugs like Vyleesi, whether there is a use case for people who have experienced genitopelvic pain in the past and have come through that, and are then, as you say, like facing this problem of, okay, I can technically have penetrative sex, but I do not want to.
Exactly.
Yeah. Okay. Let's go back to talking about the 2 approaches, or the 2 protocols. So for a clinician who uses Botox in maybe the more like traditional way for vaginismus, what does that actually look like? And how does that differ from is it Pacik?
Yeah,
Pacik Multimodal Protocol?
Yeah. So the traditional way, and, and this is where we get a lot of these horror stories, these patients are awake. And so you already have someone who is heightened anxiety, and you're like, I'm going to stick a needle in your genitals. And, we maybe will numb it or something like that first. But then, as you know, I mean, lidocaine, bupivacaine, whatever, it does not feel good either. So, you've got to go in and get through the mental aspect of first allowing someone to do that, if they have vaginismus, how are they going to relax enough to allow that to be done to them? And so that's kind of the typical way. And that's honestly, I think why a lot of times Botox doesn't work as well is because it's not done in a way that's conducive to it working well. And so when we do the Pacik protocol, our patients are under anesthesia. Typically, they're in kind of a twilight sleep using propofol or something like that. So we can feel the muscle spasm, but they do not feel any type of discomfort. So we're able to go in and say, okay, we need to do it here, need to do it here, need to do it here. Now, and I personally, after we're all done, we'll make sure that there's numbing done kind of around the tissue so that when they wake up, they're not hurting. Botox burns a little bit just naturally. And if you're already kind of at that heightened awareness about your genitalia being in pain, to know that, well, okay, even when you wake up, it's going to burn a little bit. A lot of times that's kind of not helpful either. So the goal really is that when the patient wakes up from the procedure, they're not feeling anything. They actually feel, they're like, oh, wow, I don't hurt. And we do something different with our dilators with that too, because we're actually dilating them while they're under anesthesia. And so they wake up with a dilator in place. And for some patients, this is the first time they're able to remove a dilator, put it back in without any type of discomfort at all.
It's a very interesting protocol. And so the key elements, if I just repeat it back to you, is this point around being in this place in between, like being asleep and being under full anesthesia. What does that feel like? Is it being like being somewhere in between awake and sleeping?
So the most common thing that I think people in the US may have associated with is either if they've had their wisdom teeth out or have had a colonoscopy. So you are unaware of what's going on. Now we can talk to you, and you kind of go, but if we're like, okay, we're going to move your leg or whatever, like, patients will sometimes help move their leg or they'll do things like that, but they are not aware really of what's going on. And the actual pain threshold, because like I said, we're numbing things up too. Like we have people that, like I said, they get a good number of injections in very sensitive tissue and they don't jump or bulge or anything like that. So I think that is really part of the key with it, is making sure that the patients are comfortable. Because that's a big fear component too. If I were to tell you I'm going to take this needle and stick it in your vagina 40 times while you're awake, oof, here's a Valium or something, like that's not gonna cut it.
Yeah.
So.
And it's interesting, I guess, also this level of sedation versus general anesthesia that you're targeting here is also alluding to the point you made earlier in our conversation regarding that if you're under full anesthesia, then those muscles that spasm very heavily or very strongly will ultimately relax if you're under full general anesthesia, right? So you need to have that sweet spot where you target the right muscles in terms of the ones that are continuously spasming. And this type of sedation allows that.
Correct. Yeah. Full endotracheal anesthesia where you are fully paralyzed, like most surgeries. I mean, is that you are fully paralyzed. That's why you have, the anesthesia machine that's breathing for you and doing things like that. And so with this, patients are breathing on their own. They're, like I said, it's basically just kind of turning off their awareness.
And can you tell me a little bit more about this logic of, because I understand like the purpose of injecting the Botox while they're sedated so that part doesn't hurt, and that isn't like in and of itself a really difficult thing to go through. But the logic of using the dilators also while they're in that state and waking up with it. What can you tell me a little bit more about that?
Yeah. So you'll occasionally find patients who may have something like a hypertrophic hymen. So the hymenal tissue is really thick and it won't allow the dilator to pass through uninhibited. And so even if you were to do all that, they still now have a physical barrier that they're hitting. So when we do the Pacik dilation, we basically dilate up to roughly a size 6 dilator.
On a scale of 10 or?
They go up to 8 millimeters, and most vaginal dilators are roughly the same width. A size 1 is roughly the same width no matter what brand you're using, and kind of up and up and up and up. The Paciks go up to a size 8. We dilate on average up to a size 6 with patients. But what that does when they're asleep is that lets us know that there isn't anything that's actually physically impeding the dilation.
Okay.
Because if there was, we'd want to take care of that.
Right.
And then they wake up with the kind of small to medium dilator in place. And, like I said, for some patients, the ability to remove that dilator, and I work with them in the recovery area, remove the dilator, they're able to put it back into place. I mean, it's like you see people like their brain doesn't know what to do. Like it's kind of it's my favorite part of the whole experience. And then they take it out, they put it in, they're like, oh my gosh, this isn't hurting. Like, what is going on? I don't understand this. And patients start crying, and it's a very emotional response a lot of times because, now it's like they've proven to themselves, hey, I can have penetration and it can be pain-free.
And I imagine that maybe in your practice, you also get a lot of primary vaginismus patients who have had that their whole life and never experienced being able to do any type of penetration pain-free. Yeah. So yeah, that's really interesting. And actually one thing I wanted to mention now that I forgot to mention when we talked about the 5-point grading scale, which I thought was really interesting from the study that came out, which you did, was that you were referring to this concept that a lot of patients talk about of hitting a wall, which I thought was really interesting. And I think I would love to hear your view on whether that feeling of like physically nothing can go in type of thing, is that only associated with grade 5 severity, or can you have that earlier as well?
You can have that. That is with any grade, honestly.
Okay.
Maybe not so much a grade 1, but even initially, so that's the thing that either the patient or in the case of like a partnered sexual activity, the partner trying to penetrate with something and they feel like nothing's going past this. So no, that is irrespective of grading.
Okay, interesting. And one thing that arises for me when talking about this is, and I don't want this to come out wrong at all, but is there not a risk that this is perceived as some form of a trauma by the body, that, you're under sedation, you're not fully there, but you are being being penetrated with a dilator? And I'm asking this also considering the fact that unfortunately, many people in general, but also particularly with vaginismus, have a history of sexual trauma. Right. And to be very transparent with you, that is actually the case for myself as well. So I have kind of firsthand experience of just how deeply traumas can be buried in your subconscious or in your memory and then resurfaced later on. So that was one of the things that I was thinking a lot about in preparation for this conversation and would love your view on.
No, and I think that's incredibly important to mention. And that's one of the things we talk about with patients when we're doing kind of the evaluation and preoperative kind of workup for this. And I think this is where trauma-informed care is incredibly important, and patients are aware when they decide to have the procedure, what is going to happen. And that agency that they have in saying, yes, I am wanting to do this. I know this is going to happen. I think that is what separates it, personally. Now, obviously, it is something that, we have had a couple of patients that afterwards, they're like, I just can't do the dilation. Like, because that's the other part of this we haven't really talked about is, what do you do after the procedure, Yeah. But as far as the procedure itself, I think saying, hey, this is what's going to happen. We're going to get you good and comfortable. You're going to be in this kind of twilight sleep. We're going to do an exam. You are, like you can kind of respond to things. Like I said, they're not going to be doing calculus by any means, but, they can kind of answer some questions or things, and making sure, and this is my own little idiosyncrasy, but I even tell the patients what I'm doing while they're asleep, whether they can hear me or not. I think it is at least they hope, they recognize my voice. I always make sure I'm there with them when they're put to sleep too. That's the other aspect. So even if their subconscious is still kind of active, they know that there's at least someone that they're familiar with there, and I'm walking them through what I'm doing and I'm telling them what I'm doing. And I think that helps. That could be totally, woo-woo or whatever, but I think it makes a difference.
I think so too. That's really helpful context, I think, and something that I think would reassure a lot of people listening, because it is I guess a vulnerable position to be in, right? Yeah.
Yeah.
But so can we talk a little bit more about what happens after the procedure in terms of what the program looks like? How long does your typical program last afterwards, and what does it encompass?
Yeah. So the Pacik protocol, basically it was for 3 months following the procedure. And in the first month, we're having patients dilate 2 hours during the day, typically 1 hour in the morning, 1 hour in the afternoon. and then they're sleeping with one of the small dilators in place every night.
Oh, okay.
The second month, it starts to kind of scale back to where they're dilating for a total of 1 hour during the day and sleeping with it in like every other night. And then the third month, it's dilating for 30 minutes during the day. And then, twice a week or so with the sleeping. And the purpose behind all that is obviously that's a longer dilation period than a lot of other dilation protocols, use. But the thing that I will also say is that the dilators that Dr. Pacik actually developed for the program are made to be worn when you're doing other activities. So they're not long. They're actually fairly short. The diameter increases. But I've had patients who are teachers, nurses, wearing them while they're working, people going shopping with the dilator in, things like that.
Okay.
And so they're also flanged on the bottom. So your underwear will actually hold them in place overnight. And so what that does is it reinforces that something touching that tissue is not dangerous, both when the patient is active and moving around and everything, but also when they're sleeping. And so their subconscious gets that too, that, okay, even in a situation where I'm at my most vulnerable, something touching this tissue is not dangerous.
Okay, very interesting. And you mentioned it a bit earlier in terms of success rates, which I think you mentioned was measured at 3 months after the procedure.
So by 3 months, by the end of that third month, having pain-free penetration is the goal.
And I think you mentioned it was around 90 to 95% of your patients who were experiencing pain-free sex after those 3 months. Is that correct? Yeah,
correct.
It's very impressive. One of the things I was curious to tease out is Botox is not permanent, right? It kind of temporarily interjects in that messaging between the nerves and the muscles, right? So what does long-term success rates look like from this treatment?
Yeah. I mean, the vast majority of patients, especially once they're able to have pain-free penetration, this sounds kind of crude, but they're using that penetration as a type of dilation. And so they don't need to have the procedure again. There have been, I think in the total time I've been doing, I've had 2 patients that we've had to repeat the procedure. And both of those were instances where there were significant changes to that patient's either health or relationship status or things like that.
Okay.
That in the interim.
The fact that most patients don't relapse after the Botox wears off is, I think, really fascinating to me, because that suggests that the kind of neuroscience of chronic pain is a very big component, right? How do you think about that?
No, I think that's entirely, I mean, the more I get into this field, the more the autonomic nervous system and the brain-body connection, shows its face. And so I think that when you can rewire that neural circuitry to say that something touching this tissue is not dangerous, then that you don't have to have the Botox there to keep the muscles from spasming, because it's not going to. You're not going to have that fear response from it.
It's incredibly fascinating. And so let's talk about who this is for, because I'm assuming not everyone with vaginismus is going to need Botox. So maybe going back to that 5-point grading scale, at what point does Botox kind of become the recommended path versus other forms of treatment alone?
I think definitely for grades 3, 4, and 5, this is the best way, in my opinion, to take care of it. Grade 2 patients, a lot of them can still benefit from it, but there are ones that are really good at doing, the dilator, the cognitive behavioral therapy, things like that, and they may not need it. Like I said, it's an accelerator to it.
Okay.
Your grade 1 patient, I think I may have done this on like one grade 1 patient, but I mean, a lot of those, we really try other things first to get them to be successful. But I mean, technically you could do it for anyone that had Botox or anyone that had vaginismus. It just may be a little bit aggressive for some individuals.
And so I wanted now to turn to vulvodynia and the case of using Botox as a treatment for chronic vulvar pain. So can you tell us a bit about the cases of vulvodynia where you would consider Botox for, and whether it's something that you do in your practice?
So it is something I do in my practice. And the big things that we're going to see now, if you imagine that pelvic floor as those muscle groups, we're now going deeper into the pelvic floor. and more specifically where you actually get a lot of nerves coursing through those pelvic floor muscles. And so the patients who Botox is going to have a really meaningful result in with vulvodynia are those that also have hypertonic pelvic floor dysfunction.
Mm.
And so what we're doing with that is, if those patients have pain with penetration, especially deeper penetration, if they have pain after sex, if they have pain after orgasm, anything where those muscles have been stimulated and now are kind of contracted in that hypertonic way, the Botox can go in and do a similar effect. In our practice, if we are going to Botox someone for vulvodynia, we are also going to get them in with pelvic floor physical therapy. Because while we go in, we relax the muscles, then the pelvic floor PT can go in and rehabilitate the pelvis and the surrounding muscles so that when the Botox wears off, everything is coming back online to a position of strength. And that's why we rarely have to repeat the Botox for the vulvodynia.
And so you're saying that the muscles that you would target with Botox treatment for vulvodynia isn't necessarily similar to what you would for vaginismus, which is more focused around those entry of the vagina muscles rather than the deeper ones.
You could, and obviously every person's going to be different, but it is, I would say, more often than not, if you kind of think of the first layer at the entrance, second kind of in the middle, and third deeper, that second layer for vulvodynia patients around the iliococcygeus muscles are almost always super duper tight. The third layer getting back towards the obturator, where it kind of connects with the hip, especially if they're long-term vulvodynia patients, they will almost always have some hip involvement with those. And so those are typically where we're doing that. Now, if they have a lot of pain at around the 6 o'clock position of the vestibule, that correlates with a lot more of the superficial or kind of introidal pelvic floor muscles. So in those patients, you may do more Botox in that kind of first layer of pelvic floor musculature.
Do you use the Pacik protocol also for vulvodynia patients? So you also do it under sedation, or does it differ?
Yeah. No, I do all of my Botox really, if we can, under sedation. I think it just works better and patients tolerate it better. We're not doing the dilator therapy for these patients, but the same way in which I was trained kind of doing the peppering technique with the Botox and that dilution is still the same type of thing.
I always like to end on a really optimistic and kind of forward-looking note. And I guess our conversation today has been very solution-oriented and very optimistic in that sense, I guess. But I'm curious to hear, what are you most excited or hopeful about right now in terms of either how we understand or treat vulvovaginal pain, and not necessarily talking about Botox as a treatment option, but just in general?
I think that it is really getting to a point where people are appreciating it more as its own thing. Vulvodynia is an umbrella term. It just says you have pain in your vulva. And for a long time, that's what people got diagnosed. And maybe here's some medication or try some PT, but it wasn't as focused in what's going on. And I think what we will see in the upcoming years is really almost like region specific, similar to what we have for patients with persistent genital arousal disorder, in which case you say, okay, this is what's causing the pain for this patient with vulvodynia. This is what's doing it for this. It's musculoskeletal, it's neurologic, it's dermatologic, whatever it may be. The other thing I think that is really going to be hitting big is the association with mast cell activation syndrome and patients with vulvodynia and vestibulodynia. I think we are just at the tip of the iceberg with that. And there's some of us that are kind of, we're I call us the second generation ISSWSH, kids. The first generations founded it and they provided all of the kind of big infrastructure. And now there's some of us kind of in my generation, like Jill Kraft and Rachel Rubin and Kelly Casperson and kind of people in that range of things that, now we're starting to see some ways in which we can take this data and we can hone it in more onto specific causes of things.
So inspiring. Corey, thank you so much for being here.
Oh, thank you.
This was truly such an insightful conversation, and I just love picking your brain, and I'm so grateful for the work that you're doing in this field. So thank you.
You're very welcome. It's my pleasure.
Thank you so much for listening to this episode with Dr. Corey Babb. I really loved this conversation, and I hope it gave you a clearer picture of what Botox therapy can look like and whether it might be something worth exploring for you. If this episode was helpful, please share it with someone who might need to hear it. And also, if you haven't already, please follow the show so you don't miss what's coming next. I have some really exciting guests and topics lined up that I truly can't wait to share with you. So, as always, thank you for being part of this community, and I'll see you next week.